We are a medical weight control practice. That's what we do best. Weight control means we want to be your long-term solution. Weight loss should be a small part of the timeline, and we want to be responsible for keeping that weight off or guiding you to keep that weight off for the rest of your life. Obesity is unhealthy weight that either causes diseases or increases your risk to have diseases. It's related to this MRI that yellow is fat or adipose tissue, dark brown or black is hair, white is bone, and then red or shades of red is going to be skeletal muscle. White can also be neural tissue, so you can see the brain is the white, pinkish. The 250-pound gentleman here, focus just in the belly. You can see how much yellow, and you see these dark spots over here. That's airspace in the intestines, and you can see a ring around this heart right there, and that ring, that's fat too. All of this fat that's inside the belly is what we call visceral adipose tissue or visceral fat. This fat out here is called subcutaneous fat. We actually term that healthy fat. Okay, I know it's not wanted, but it doesn't cause disease. Compare his inside of his belly to her inside of the belly. Look at, there's not much yellow there, right? You see the liver light up in her. That could be various reasons. She might have some fatty liver disease there, but there's not as much yellow in her belly, and there's no ring around her heart. You see that? And so it's almost like a night and day kind of picture. Yeah, she has some fat right around the hips. Everyone has to have a little bit of or beneath the skin fat. And that unhealthy weight leads to what? Look at this mess. This is 2015 data from the CDC. You can see the cancers over here associated with it. And there's a whole host of it. Just the bottom line is that visceral fat leads to badness, early heart attacks, diabetes, all the usual metabolic diseases, and cancers. If you understand the why, those of you who've ever listened to Simon Sinek, the why, if you understand the why, you're more likely to change your life, right? Why do you need medications? What is nutrition? How do we change it? Should we change it? What about exercise and physical activity? Is there a difference between those two? How much we got to do? Everyone's got watches for the most part now that monitor all these cool things, but most people don't even look at the data. What data should you look at that gives you the most powerful and most meaningful results? An obesity medicine physician understands all 5 parts and develops a plan involving all 5 parts to treat that belly. We want to shrink that belly. I will teach you what gives you the highest probability of success. If you'd find success is keeping the weight under control or keeping it off. How much sleep? Show me the evidence on sleep. Do you really need sleep to keep weight under control? So if you understand all 5 parts, you're more likely to be successful, success being that you keep the weight off. Notice we don't focus too much on weight loss here because weight loss is temporary. We want to achieve weight control. To do that, I need appointments. So if you're under self-pay, those are our prices. If you have the insurance model, then you can see it's going to be copay deductibles. If there's any care between these appointments, let's say you need an extension on a medication that you could make follow-up, there's a $35 service fee for that. Cost of medications can be high. Our job is to figure out which one your insurance will cover. We have different processes for that. Technology cost, that refers usually to the watch. So if you already have one of our approved watches, then your cost is low. I prefer Garmin, and we'll give you a list of devices. This is our usual timetable. On the first appointment, we'll talk about why you need medications. Then we see you every 2 weeks and we go over your labs. We do a tech seek, and then 2 weeks later, we go over nutrition. You can see the rest of the schedule down there. There's a lot of training up front. I usually call it basic training because of my experience in the Army. Once you finish basic training, then we start going monthly and you're on top of the program, you're losing weight, you're doing well. Then I start spacing it to every 2 months. If you're doing really well, we go every quarter. I usually see everyone every quarter. There's something special about the 90-day follow-up. I've noticed that both in business and with medicine. So 90 days seems to keep us on track. How do we regulate our energy and our appetite? Okay, so here in this picture, there are 2 regions of the brain that communicate with each other here that in essence controls our energy and controls our appetite. And they interact with each other here. This pink area located on the brain stem of the brain senses this hormone called ghrelin. Ghrelin comes from the stomach. And when I first learned it, it sounds like gremlin. And sure enough, when that is higher in concentration in the brain, guess what? It's time to feed. So when you feed, you bring in all this nutrients into the GI system, and it activates GI system, and the GI system starts to release hormones. And even though you only see 2 highlighted as blue, all of these hormones that release are actually appetite suppressing hormones sensed by this region in what we call the hypothalamus. And you can see then we start to store that fuel as energy, and fat does release hormones, and those are appetite suppressing hormones also. To simplify it, ghrelin makes you want to eat. These other hormones suppress your appetite. So there's always a concentration issue in the brain. Which one has more concentration? If there's more ghrelin, time to feed. If there's more appetite suppressing hormone, then you're full. The brain works is better characterized maybe by this metaphor.
I like to talk to my patients using this gas tank metaphor. So let's say normal is a 10-gallon tank in your body. Your brain wants to feel that 10 gallons, right? So as you go through the night, you burn those calories and that purple gap, and you see the green box go down. Then you wake up in the morning, you're hungry, so you eat some breakfast, goes back up. Same thing happens during the day. You go through lunch, or you go through your morning, and then lunchtime is triggered by this hunger gap, and same thing for dinner. But that's how this works. Then we start to screw it up by eating way too much, and then the hunger gap goes up, or our fuel level goes way up and above, but we don't spill it out. What ends up happening is your body adjusts by increasing your gas tank, so now your brain wants to feel 20 gallons of gas all the time. When you start to lose or go through your normal day, you still have this same hunger gap that increases overnight during your day, but then you start to lose a lot of fat because you're trying to lose weight. You have this huge hunger gap. So what do we do now? We want to replace that hunger gap with medication, and that's tricking the brain to feel like it has 20 gallons. As you lose more weight, as you see here, if you keep the same dose, that hunger gap returns. That's progress, and you'll need to increase it. That's how we use obesity medicine. That is the set point explained as a gas tank.
How do we solve this 20-gallon tank issue if we want to get back down to 10 gallons and feel full? Instead of using fat, the only way you control it without meds is you have to have fat. So you have enough of these appetite suppressing hormones that you produce through food to make the brain feel satisfied. What happens if we just gave you appetite suppressing hormone directly, and your tank is at 20, you go down to 10, and then we just cover the gap? And that's what we're doing now, and that's the whole genesis of obesity medicine. So this particular hormone is the one we're going to use is called GLP-1, usually is what we start off with. Glucagon-like peptide comes from a small intestine. You actually make this one. When the stomach digests the food, places the nutrients in the small intestine for absorption, and then this hormone gets released. It's a blue hormone, so it goes up to the hypothalamus. It suppresses hunger, and there's a feedback loop to the stomach. This is a hormone of satiety. That's why they call this the brain gut hormone. It decreases your hunger cravings, and it also makes you feel full. I usually like to start with Wegovy or semaglutide. This is also known for diabetics as Ozempic. Other medications in this class include Mounjaro and Zepbound, which is the same thing as Mounjaro, just a weight loss version. We had an old one called Byetta. It's still around for diabetes, and Victoza was the daily version. The weight loss version is also known as Saxenda. Most common side effects of the medication is a GI medication. Most medication, if you actually look at the list of most medications, they'll have nausea listed. Usually within 48 hours, the symptoms resolve. This is a weekly injection. Pancreatitis, very scary. It can be something that does occur. Does it cause pancreatitis if it's a common side effect? Not directly. If you look back on this other slide, on the medical complication, unhealthy weight, pancreatitis is listed there. People who have unhealthy weight are at increased risk of pancreatitis.
What is pancreatitis?
Pancreatitis is inflammation of the pancreas. That's all that means. It's inflammation, something caused it. It would be pain, usually where the two ribs meet together, and it'll be dead center. It'll be sometimes a very deep pain. If it's severe pain, you should be going to the ER to have that evaluated because you're not sure what that is. Now, it does not cause pancreatitis directly. People who have unhealthy weight are at risk. And then if you lose weight very quickly, you can form gallstones, and those gallstones can travel and get stuck in the pancreas. Pancreatitis is potentially a fatal condition. And so that is something to be aware of when you're taking this medication. So it's not a direct effect. This medication is probably good for the pancreas, but it's listed there, so lawyers make me tell you. Contraindications, rare thyroid cancers. This happened mainly in the rats. During the clinical trials with the rat and the mice, high levels of GLP-1 cause mice and rats to have thyroid cancers. And at the time, the scientists said those thyroid cancers are similar to these human thyroid cancers. There's been multiple studies on this, and we have not seen an increase in these two thyroid cancers. This class medication has been around before 2009, so we already have 15 years of data, and we have not seen a convincing connection. If this was really going to cause it, we would have an exponential rise in those thyroid cancers.
In the next video, I'll show you the most up-to-date options that we have for the GLP-1s or the injectable medications. I'll see you soon.